Good afternoon, ladies and gentlemen. Welcome to this plenary session of the first day of the Cystic Fibrosis Conference. As you hopefully are aware, this plenary session will look at what are the real costs of cystic fibrosis. And I'm sure you're now familiar with the calibre of the various speakers at the conference, and this session, of course, is no different. I'm going to quickly run through a brief introduction of all of our panellists, some of whom I realise through previous sessions you may have already been introduced to. But Professor Barry Plant is a consultant respiratory physician and the director of the Adult Cystic Fibrosis Centre at Cork University. He's the chairman of the Medical and Scientific Council in Ireland and a former national coordinator of the European CF Conference. Professor Pradeep Singh is the professor in the departments of microbiology and medicine and director of the Cystic Fibrosis Research Development Program at the University of Washington. His clinical interest is in the care of adults with cystic fibrosis. Sian Ellett, as we've heard, is a writer, an orator, a practitioner of meditation, and a person who brings a very unique perspective to the issues concerning the costs of cystic fibrosis. Susan Bigger brings a parent and a consumer advocate's approach to the issue of cystic fibrosis treatment. 2 of her 3 sons are living with CF. She's a consumer representative on many health-related committees and the inaugural chair of the Royal Children's Hospital Family Advisory Council. Frances Hollander, for almost 30 years, has been working as a dietitian in adult patient care at the University Medical Centre of Utrecht in the Netherlands. She has a deep interest in evidence-based dietetics and participates in the Dutch Adult CF Dietitian Specialist Group. Eleanor Main her focus is on the clinical efficiency studies in physiotherapy. Eleanor is a professor. She's a program director for postgraduate studies in physiotherapy at University College London and teaches and researches at Great Ormond Street Hospital in London. John Massey is the Associate Professor, Respiratory Physician at the Royal Melbourne Children's Hospital. And David Isaacs is the Clinical Professor in Paediatrics Infectious Diseases at the Children's Hospital Westmead and the University of Sydney. Could I ask you to welcome all of our panellists? As I mentioned, the topic for this afternoon's plenary session are the real costs of CF. Now, obviously, that extends beyond the purely financial, while not forgetting, of course, the financial burden can be onerous. The reality of cystic fibrosis, as many of you know and some of us are learning, is that it engages many elements, from the pathology of the condition through to emotional, physical, psychological and financial challenges faced by patients, families and the medical practitioners and related healthcare professionals. So this discussion will hopefully be a chance to explore some of the issues that each of those groups encounter. To begin, what I'd like to ask each of our panel, moving from Barry across, just to give a brief idea of when they see the topic, the real costs of cystic fibrosis, what's your initial response?
That's always hard because you always respond after everybody else. The cost, I think the immediate knee-jerk in the current environment is to think that the cost is about money, because at the moment, as Claire I think highlighted, we're very sensitized as a community because of the next generation of therapies. But I think the cost, when I think about the cost of CF care, I think the cost really is ultimately going back to the individual. What are the challenges for the individual with CF? And for me, it's the adult with CF, or young adult onwards with CF. And what are the challenges that they have, be it cost in time, cost in emotion, or cost, I suppose, in financial. So I think you're immediately thinking money, but I think at the end of the day, that's that's only one aspect of it. That's my immediate thought.
Right, thank you. Pradeep?
That is a difficult question. I think that I would say my answer would be informed by my experience as a parent. And that is that the most important thing one wishes for one's child or a loved one or anyone is the capacity to reach their potential in life as they define it. And CF and other chronic illnesses threatens that, threatens a person's capacity to reach their full potential. Doesn't end it. It doesn't. It can be overcome, but it threatens it, and I think that is the cost, and that's the cost that I think if we talk to our patients about in so many words, they'll tell back to us, or at least that's been my experience.
Thank you.
Yeah.
Sian?
I think my response to the real costs of living with CF is that, for me, learning to live beyond them, beyond the ones I experience and the ones I imagine, that in fact focusing on the costs doesn't always help.
Susan?
Yeah, so when I was posed with this question, I did a bit what Claire did, which is I asked sort of an informal poll of about 50 CF parents, mostly moms, who responded, though a few dads, and because I really wanted to have a sense of what they felt was important. And they came up with a couple of things. Probably the single biggest was the long-term emotional stress and the what was called by a few people chronic sadness, or the fight against chronic sadness. I thought that was quite moving and very indicative. And another one, which was very different but also important, was they talked about the impact of on many families of one of the two parents, and most often the mother, feeling that they were unable to work, or unable to work nearly as much as they had planned in their life as a result. So that they not only had a big financial cost to their family, but then they had the emotional impact and on their career and on their expectations of what they thought they might do with their life as a mother.
Francis?
Okay. As we have heard, is it functioning? Oh, yeah. As we have heard, when you're getting older, you have more problems also with diabetes. And when, as the dietitian, I have a consult time of only half an hour. And so if I want to do adequate treatment, I should have more time for this, to listen to you, to advise you adequately. So that is for me the real problem, that I should have more time to listen to the patient and to have better outcome for her.
Eleanor? I think these microphones need to be worked fairly close.
The things I think about on this topic are about the real costs of research in physiotherapy, and like all parts of medicine, we keep struggling with the ideas of what physiotherapy is best. And 38 studies between 1979 and 2010, short-term studies, didn't get us any closer. We're 5 Cochrane reviews in, and we're no closer. And I think part of the problem is that we rely on traditional outcome measures like FEV1, and also traditional ways of doing research like the randomized controlled trial. Now, randomized controlled trials are fantastic ideas, but they depend on you being able to blind people to one group or another, people not knowing what they're getting, white pill or blue pill. And the trouble with physio is that we always do stuff that's very tactile and immediate and big and burdensome. We do airway clearance, and it's a lifetime thing, and we do exercise. So you can't not know what you're getting. And the moment you don't know what the moment you know what you're getting, and you have any strong preference for it, then you start behaving badly in a randomized trial. And there's several examples of this, but the biggest one was an American study by Sontag, in which people were randomized to either postural drainage or percussion, or they were randomized to the vest. And people thought at the time the vest was a good idea, and postural drainage and percussion was boring and old-fashioned. And very soon into the study, 35 people dropped out of postural drainage, and 5 people dropped out of the vest. And the whole study had to come to a grinding halt because of this behaving badly. People cared what they were getting, and they knew what they were getting, and they were being asked to do it for a long period of time. And And so I'm thinking 38 short-term studies in, 5 Cochrane reviews, 4 big randomized controlled trials, an enormous cost to the patients who participated, because we didn't get any further forward, enormous cost in terms of the costs of research, but also enormous cost ultimately in our moving forward in these questions, because we're no further forward and a good few decades on.
John.
Mike, the further from you, the longer the answers get. So,
Sorry.
We're all waiting for David then.
buckle up, folks. As a paediatrician, you might think I want to talk mostly about the kids, and I do. To start with anyway. But actually the kids are very resilient, and this is a life they're born to, and we're keeping them healthier. And certainly the young ones, I think, really adapt to that. But adolescence comes and you realise you're different from other people, but you're the same, but you're not. And you've got to do all these things that everyone else doesn't have to do, and that's an enormous challenge. And integrating, it's a time when you want to integrate illness into your life. It's something happens to other people in someone like me in early pre-middle age, where you're starting to think about illnesses. So that's a real cost. But we try not to, as paediatricians, put any brakes on the kids. But where I see a tremendous cost is with the families and the parents. And Susan talked about chronic sadness, but I see this recurring and rolling grief. There's the diagnosis, and then you pick yourself up, and then you look at the CT and someone says you've got bronchiectasis, and now you've got Pseudomonas, and then it rolls on, and now you've got some liver disease, and then it's diabetes, it's a PEG, it's a transplant. It doesn't stop. And if you happen to be really well, you might potentially be really unlucky to have me as your paediatrician, and like Barry, be completely unsatisfied. Why is your lung function's 98%? Well, why is it not 100? What can we do to push it along? And I acknowledge that, and some of the families of the kids I look after are here, and we talk about that, and I know that that's hard. I know that I'm hard on them. Well, not them, but the illness, but that's all part of it. And I think the better, healthier we keep the kids, in a sense, the harder it is, and the more we're asking them to do. Susan alluded to families and getting back to work, and we have some nice data just accepted from in publication, but Tonya Douglas has done in Western Australia with us, and just looking at what chronic illness does to your family, and the fact that you don't get back to work, and mums often don't get back to work, and that leaves you on the bottom of the pile as you're scrambling, and it's getting harder and harder to pay the mortgage, go to school, do all those things. And chronic disease is costly in that financial sense, but it's costly in a personal sense, and lots of hopes and dreams initially perhaps felt taken away, but certainly changed. An extraordinary few people feel enriched by the whole process, but I'm not sure that that's many people. I think many people are crushed by it, and even simple things like your ability to help others, which is just a normal, wonderful human thing, and now here you are reliant on others, and that's stolen from you, and then that's an enormous cost, and that just goes on. And I see folks waiting for things to unravel, and even when things are going well, and that must be a very difficult way to live.
Thank you, John. David.
Yeah, thanks. So the real costs of cystic fibrosis are about people, aren't they? I mean, cystic fibrosis is a disease, but it's only of humans. So we're talking about humans with cystic fibrosis, and we should never forget that, of course. And I don't treat cystic fibrosis per se. I'm a pediatric infectious disease physician, and I'm here because of my interest in ethics and health economics. But I'm very conscious of starting the meeting with Nathan talking about the fact that he's first of all a rugby player, and secondly he happens to have cystic fibrosis. And Sian's touching story about wellness as opposed to illness. Susan, mum of 2 children, and my friend Mitch Messer, who's in the audience here, who's long-term friend who I met on the Pharmaceutical Benefits Advisory Committee, which is the Australian committee that makes decisions about funding of drugs, whether they should go on the Pharmaceutical Benefits Scheme, which is the equivalent of the NHS in the UK and Ireland. And so I will also talk about the costs of treatment, because I think they are important, with modern drugs costing astronomical amounts of money. And just to say that if any of you in the audience wanted to buy a new car or a new house, you'd say, well, how much is it? And what do I get for it? And that's what we need to do about drugs in cystic fibrosis, or at least as a country we need to think of it in those terms. I know you're all very much involved, either as patients or as doctors advocating for your patients, but still in the broader sense of it, we can't afford everything, and we have to think, well, how much does it cost? And what are we getting for it? And should we afford it?
Thank you. To come back to you, Barry, and one of the things that you mentioned in the previous session, you used this phrase, improved survival, increased complexity. The reality for lay people like me at this conference has been the realisation of the rise in adults with CF. To take you to that phrase, improved survival, increased complexity, does that concomitantly mean increased costs?
It does. Over time, in that, we now know that in many jurisdictions there are more adults than children with CF, and so the shift of the disease, that this is a chronic illness that people are living with and moving into adult life. The consequences of that is that there are a new era of, cystic fibrosis and the dysfunction is expressed in every organ, and so as we're getting better at treating the lung, we're learning about new phenotypes of disease that can present because one is a survivor. The cost there, I suppose, on one level for people like me as a clinician, the immediate cost goes back to, as my colleague was saying from the Netherlands, time. This is uncharted waters, and so you need more time to find your way through this potentially. For the patient, the cost is an uncertainty, because there isn't 5 or 6 studies in a cohort of things like this. And I'm reminded of the Melbourne paper on the renal phenotype in CF, the case series of men over the age of 30. And we had a similar experience, and they're the only ones that exist in the literature, and so you're trying to find your way through. So for the patients, there's a huge uncertainty to that as well, because you just don't know, you can't predict where this is going. So it's very exciting I'm aware it's a mixed audience. As a professional, it's very exciting and it's very rewarding to be part of something that you're trying to find a way through. But for a patient, it isn't easy, because you may not have the answer other than we haven't seen this before and we think it is CF related, and it's as a consequence of doing so well. And I think it goes back to the pediatric comment then, that it's almost like, well, I've done so well and now I get this. It's that's just not fair. And that's very hard to factor into the clinic, when you have someone who has done everything, we say, by the book, or and just the natural history of the condition is that in another way it's going to sneak in and try and challenge them. That is it, and time is probably the key for all of us to be able to address that.
Thank you. I want to stress, if a comment made by any panel member inspires you to say something else, please feel free. People are here to hear you. Susan?
Actually, could I take you up on that offer?
No.
To comment on what Barry said, and to focus for a minute on financial costs. I think that the hope of biomedical research is that costs will have a curve that goes up and peaks and comes down over time. For example, if we look at the cost of treating tuberculosis, there was a time when the diagnosis of tuberculosis meant you were, under institutional care for life, You might be on a machine in an iron lung for many years. You'd require many people to care for you full time. Now, with understanding, that changed. That changed to as long as you don't have a multi-drug resistant bug, 3 months of pills that cost pennies a day. That's the hope, that early on costs are very high. As understanding improves, costs go down because we're mechanistically treating the underlying causes in a more targeted way. Ulcer therapy, I think, is another good example of that. Expensive ulcer surgery versus targeting a pump that changes acid in the stomach. And I think that there is a good hope to think that this exorbitant cost period that we're going through could be a temporary period. And we shouldn't lose sight of that, and we have to kind of keep moving forward, maybe absorb exorbitant costs, the societal issues notwithstanding, and hope for this better day of pinpointed targeted therapy that could be actually much cheaper.
Susan, as a consumer advocate and a person on medical advisory committees who takes up the cudgel for consumers, what does a consumer perspective, how does it combine with your personal perspective as the mother of 2 sons living with CF?
You mean a consumer perspective on CF issues?
Well, just in terms of choice, I mean, we had a preliminary conversation where one of the issues is in some other jurisdictions there might be greater choice for seeking treatment, perhaps greater than in Australia. But consumers look for value, I suppose. And if can we bring that sort of analysis to cystic fibrosis treatment?
So I'm always nervous when I am in any way a consumer representative or a parent representative, to realize that, of course, I can't adequately represent hundreds of people. I can only put forward what I think and which is why I always ask people over and over, is this really what we think our issues are? Because I do think there's a lot of common issues. And I think that looking at whether or not we can, with cystic fibrosis, whether or not there's some very strong issues around that are similar. I guess I'm a little bit hesitant to answer your question. You can see, because I think that I'm a little bit hesitant to answer your question. Okay. Phrase it another way, and I'll try again. But I don't want to. I guess what I can say is that I think that we have to be, when you said your question about whether or not people in Australia are what I think you were alluding to, you and I spoke about earlier, was whether or not people are a bit, not trapped, but they are nervous sometimes to speak up about issues in their particular center because they don't have a lot of choice. Is that what you were referring to? Okay, so I think I think that's a factor, and I think that we need to think about how comfortable patients and families are to raise concerns, and I think when they're raising concerns, hopefully we as a community see that as a great thing, particularly if they're raising concerns that affect lots of people. So if they're raising concerns that are widely accepted to be widely held concerns, then I think we should embrace that and say that's fantastic and thank you, because you know what that's going to do? That's going to give us a better outcome and give us a better service in the end. But I think we have to acknowledge that is extremely difficult for people who feel vulnerable. And people who have no choice about their care or have limited choice about their care feel vulnerable. And I think that I love our team, and I think we're very, very fortunate, and I love the Australian healthcare system. But I think we have to be quite conscious of how do we represent people who are anxious about expressing difficult things to their team. Right. Who don't have a voice for that.
Right. Any other comments on that issue?
I have lots of other comments, but maybe you should let other people.
I'd just like to say, maybe because I represent the other side of that interface, I think you're making a very important point, and a point that we as clinicians can't forget, which is this isn't criticism, this is appraisal, and this is a chronic illness that we're dealing with. This is a journey that's going to hopefully go on for one's entire professional career. And I suppose in the same way, for us, I think as healthcare professionals, it's very important that we recognize that the points you're saying about that it takes huge courage to come into a clinic and turn around and say to me, look, I'm not really happy with what you're doing. I mean, that takes great courage because, and I think we should recognize that and we should embrace it. Equally, as you and I have discussed informally as well before, there will always be certain situations where that will happen, and the clinician will feel that they could be populist or they could be, and so they wouldn't necessarily concede on something. But I think for us to see it as criticism is wrong. I think we should see it as appraisal, and we should use it like that moving forward. And I think it's very healthy that you've actually highlighted that to us, because I think sometimes it's just the natural history of medicine, because a lot of the acute stuff we do is so confrontational even with our colleagues, and maybe we need to make sure that we recognise we're in a CF clinic and not down in an accident and emergency, or whatever.
That's right, and I think now that you've got me going, I think that the other thing I would say on that is that maybe healthcare is an area where we really, if we look at other industries and compare to other industries, there aren't many industries today where a consumer voice is not asked on most things, where there is not a community perspective and represented. I think it is health is particularly difficult, not only because people are vulnerable in their relationship with their health practitioner, but they also feel, they feel outgunned. They don't feel that they have the knowledge, or they maybe don't feel that the knowledge that they do have is respected equally. And so I think that it is a question of power to some extent, and that there is an enormous power imbalance. And I know that a lot of health professionals are really conscious of that and dislike that and want to work on that. But I think as a community, we probably need to think about how we do that.
Sure, John.
I'd just like to sort of add to that, because we talked a little bit about shared decision-making previously, and we think that we accept that as from the medical side, and in a way, sort of a traditional mode of shared decision-making is that patients are experts in their values and preferences, and the doctors are experts in the illness, and that model works often quite well at end-of-life discussions and things, but in a chronic illness like cystic fibrosis, I think it really breaks that down, and especially with a group of patients and parents who are so knowledgeable about their illnesses, and about that it's shared decision-making is different from that model that we've perhaps more traditionally been working on, and need to come together even more.
Please, Eleanor. Yep, Francis.
I would like to add something also, because you told that sometimes patients are too vulnerable to talk with difficult subjects. I think the strength of a multidisciplinary team is that sometimes the patients talk to the dietitian or to the physiotherapist about a problem, which they do not want to discuss with their physician. Sometimes when you have multidisciplinary treatment, you can tell the experience of the patient. Then maybe it's better to make the treatment adequate.
I'm just going to ask all of the panellists, I know eye contact is so essential in communication, but here we need mouth contact with the microphone. You do need to speak into the microphone. I'm sorry if I sound like
I have to swallow it.
I'm sorry if I sound like your grade 4 teacher. I want to pick up another point that was made in a preliminary discussion, and Barry, I'm going to use your comment but direct it to Sian if I may. Barry made the comment about an orthopaedic surgeon who can, within seconds, diagnose a problem that a person has and then say, this is what we need to do. You need a new hip, you need a new knee. Whereas cystic fibrosis is a chronic condition where the relationship between the medical practitioner and the patient can go over many years. It does involve courage, but it also, we're seeing adults who have adult lives. They're human beings with choices. How does that impact on you, Sian, when you now as an adult, you're no longer a child whose parents and the doctor are making decisions for you. You're a player in those decisions.
I think there are a couple of things that are important there. The first is that as an adult, I have to be my own advocate. So there's a learning process there of how do I stand up for myself? What do I need to say for myself? What decisions do I need to question from a healthcare perspective? And there's also perhaps this is not quite the question you asked me, but there's also a perspective I have that if medically there is a best decision to be made for my care and I don't understand it and I don't agree with it, but at a factual level that's what should happen, then there needs to be understanding given to me in whatever way it can be given so that I can follow that regime, so that I can mentally and emotionally understand why this is a good thing to do and why I'm going to adhere to it and why it's going to be good for me and believe that it's going to be good for me, and that's going to impact on how well that treatment works for me.
Right. Eleanor.
Sian, thanks. And I think I sometimes struggle with this idea of the illusion of shared decision-making because sometimes in a clinic, shared decision-making sounds like the doctor or physio saying, here's what I think you should do, and the patient saying, well, I completely agree with you, and then they go home and they don't do that thing. Yeah. And then there's almost a collusion in that, because we know from the literature, and certainly in physio, that around 80% of people do as they're told in paediatric care, and less than 50%, and this includes physiotherapy and taking medicine apparently, will do as they're told as adults. So that shared decision-making actually becomes a really difficult thing in adulthood. And as you say, Sian, if you don't understand or agree with what's being suggested, and you don't have the courage in the clinic to say so, then you might just go home and not do that thing. And that's the difficulty, is this collusion of dishonesty in a way, and it makes it difficult, doesn't it, to do the right thing.
Perhaps the doctor should just toss up. Heads you take it, tails you don't. But how, as a patient then, should we, because we all struggle with this as doctors, even if we acknowledge that we know that patients aren't going to be very adherent to our treatments, how should we talk to you about it? Mum or Sian? Susan is a mum or Sian?
I feel like that's a big question because how you should talk to me about it or how you should talk to a patient about it is actually also about what the culture is around what right does a patient or a person have to their own care, to their own health, to their own understanding of their body. And if they've grown up, you know, attending clinics their whole life being told that other people know more about them than they do, they might not be adhering because their way of having control is to not do what those people say. So that's a different issue than understanding. And it's going to be different for each person. You know, is this a person who's rebelling for this reason or for a completely different reason? This is a person who thinks that their care and feels that their care, in fact, is going to be better going in a different direction and so doesn't adhere because of that.
So you talk about it as if it's a confrontation almost, and clearly that's not how you want it to be.
No,
but I just wonder how you would have liked the doctor to put it so that you felt you were really making the decision about your own health.
I don't know if I can answer that in 10
not be a
seconds
doctor,
of thinking.
yeah.
Your time starts now.
Yeah.
I guess maybe there needs to be a shift in understanding that a patient is equally a part of that decision at a real level, not at a I'm going to just pay lip service to explaining this thing to this person and making them follow what I know is right, as, say, a doctor or a healthcare professional. And I don't know how you change that necessarily.
And can I just say that I wonder too, what, you know, we do think about things as being right, the best decision, the right decision, but of course it does depend. And we had a circumstance recently. So my two eldest sons now are 19 and just about 17. And with the 17-year-old, where he probably, I think his doctor and I thought it would be a good idea for him to come in and have a tune-up. And he was sitting the three of us were sitting there chatting, and he had really had sort of steam coming out of the top of his head. And so the two of us just kind of continued the conversation and left it there. And I was thinking, you know, this needs to be his call on this, and I think his doctor was thinking the same thing. And we kind of continued a conversation about other things, cricket probably or something. And then eventually Oliver said, you know, I think I've been thinking about it. I think I'm going to come in and have a tune-up. And Sarah, this doctor said, what did he say? Something like, mature call, Oliver, good call. And, that tune-up, I would have to say, from my experience, was the whole going in process was actually a breeze. Because we didn't walk out of the room. Usually what happens is he says, okay, I'll do it. We walk out of the room and he turns to me and says, I'm not coming in. I don't want to come in. Why am I doing this? Right? And it was just not that. It was his decision. And that might sound like a minor thing, but it was actually, for me, it was a shift. And it was a shift that it was very much a sort of he owned this in a way. And I think particularly with younger people, it's hard to respect them and to respect their knowledge. And my elder son, who's now moved to the U.S. to go to university, he had an experience in April, and he felt the worst thing about his experience in the hospital was how disrespected he felt he was as a pediatric patient. He's still a pediatric patient in that, without a parent there, but a girlfriend there. But they both felt highly disrespected because they just, he said, people kept saying to me, well, you're 19 and you don't know how to make good decisions about your life. Not exactly, but I don't think they meant it that way, but that's the way it was perceived. So we really need to think about if what we want is for people to take that decision in a responsible way, then we maybe have to live with them making some decisions slightly differently.
Yep, Barry.
Just a comment, Shen, going back to your comment about being treated equally, I actually think that's actually the wrong premise here. There are no... an adult is an autonomous individual. I mean, there is no equality or there shouldn't be equality in the clinic. I mean, you can do what you want to do. I mean, I don't know where we're losing track of this. You can get into a car and you don't have to wear a seatbelt and you can drive at 100 miles an hour into a wall. Anyone can do it, and a doctor can tell you it's bad for you. But I actually think this is an important concept. Again, on my side, I suppose what my role, at least this is what we aspire to, is to tell you why you shouldn't drive into the wall, and you should wear your seatbelt. If you choose not to do it, that's your decision. And I mean, whether you've got cystic fibrosis or not, it doesn't change that, or at least it doesn't for me. What does change for me is the need to tell you, because I'm not using you, that it would be us, but if I'm in an interaction with someone, they must know what my concerns are, because they are what, if you believe that ultimately the house wins, in 100 people with CF, this is what will happen to the majority if they all drive into the wall. And so once people know that, then they can make a decision. And if that decision works for them, fantastic. And if it doesn't, and they have a negative outcome, I'm not going, I told you so, but what I'm actually doing is I'm comfortable that at least I was honest with the individual and said, and told them and warned them, as it were. And I think that's an important kind of concept that we've got to get around, because there are ultimately no rules. Someone can live as they want. And then getting back to the childhood issue is I think that there isn't equality for kids. At least I'm not a pediatrician, but I don't see that there is, because probably the parents have a more dominant role. So that they're just my thoughts. I think equality shouldn't come into it. You're an individual.
Can I just make a side note to something you just said? Perhaps your patients might follow what you say better if, instead of saying this is what will happen if you drive into a wall, you say, this is what will happen if you don't. These are all of the wonderful, good things that could happen for you if you follow this belief that I have. That
absolutely, no, and I concur with your thoughts, but equally, but I also, we don't have a crystal ball, and this is the other side of all of this, is we do see people who do everything perfectly, and still, unfortunately for them, circumstance or chance, things don't work out either. So I don't think I suppose what we're trying to do is be advisors of risk and benefit.
That's right, and you're trying to get your point of view across and your belief across in the best possible way.
David,
I just had a comment about children and respecting their choice, if you like. So I'll tell you a story completely separately. I don't look after many children who have cystic fibrosis, but I run a refugee clinic. And so on Friday, I was doing the refugee clinic 2 days ago. And there were 2 children there that I was seeing, very bad post-traumatic stress disorder. And one of them needed blood tests doing. She's 9 years old, and I said, do you want the magic cream on, which means that it doesn't hurt? And she said, yes. So we put local anaesthetic cream. She went down to get her blood tests with her mum and the interpreter, and I got a phone call in the middle of my busy clinic to say, she's screaming the place down, she's very strong, she doesn't want her blood tests. And I said, well, tell her she doesn't have to have her blood test. She can choose not to. Don't fight her, just, that's fine. She doesn't need her blood test that desperately. And half an hour later, I got a phone call to say she changed her mind and she decided to have her blood test. And I went, oh. And I think that's about respect of choice and so on. Maybe it wasn't anything to do with that, but I just think children change their minds sometimes, but they do value being respected. Anyway.
Just on the issue of it, sorry, did I interrupt someone?
Yeah, I just wanted to make one point I think that was raised. It's an issue that I shied away from early in my career, but I've come to embrace, and that is very openly discussing, and Barry mentioned this and touched upon it, very openly discussing the fact that the recommendations are tied to probabilities. You know, we don't know what will make the person in front of us necessarily better. We know that there's a higher probability if course of action A is taken versus course of action B. And I felt earlier in my career that acknowledging the amount of uncertainty that we have about CF care and how to do it and what makes people better and what makes people worse might hinder the patient's confidence. But as I've come to realize, I think putting a strong emphasis on the fact that recommendations are tied to probabilities of success or improvement or non-improvement, it does 2 things. Number one, it tacitly gives the patient permission to say, well, that may be your estimation of the probability, but I prefer to do the following, and that's a reasonable probability as well. And the second thing it does is that if the patient does comply with the treatment or choose the treatment and they end up getting sick anyway, it removes the element of blame that they didn't do something right, because this was framed as a choice between competing probabilities, and those could go either way. And so, to me, paradoxically, acknowledging uncertainty and has improved the ability to have these kinds of conversations.
Francis, I'd like to pick up the point of choice, and particularly say if we look at dietitians, a dietitian's approach. The idea of food diaries, adherence to food diaries, choices about enteral tube feeding. What's your perspective on those? Are there options there? Say with a food diary, is it critically important that it's fulfilled to the letter? And what happens if it doesn't?
I shall try to swallow this microphone. I think it's important that you should always keep in mind that you have the same goal in your treatment, so as a dietitian as a patient. Because I would like to tell you a little story about a girl who needed enteral tube feeding. And it was because her weight was declining and her lung function was declining, and her BMI was below 80.5, so that's an indication to start with enteral tube feeding. But when I discussed this with her, she wasn't intended to start with it. But then she told that she was going to marry within half a year, and she has to fit her wedding dress. So she would look normal in a wedding dress, and that's why she started with the enteral tube feeding. So it's important to know what your treatment is and what is it the same treatment or the goal that the patients want. And then you have adherence, I think.
It so reinforces that we're dealing with human beings, doesn't it? That there are all these other non-medical concerns and aspirations and desires that people have, and that are fundamentally important to how they define their lives. I'd like to come to talk to Eleanor about ideas of the sort of contractual relationship between the medical professional and the patient, and the idea that it may be necessary to come up with a new way of working around honesty. If someone's not doing what the medical practitioner has asked them to do, is the better way to avoid the blame game to not have a contract based on we agreed to do this, but perhaps one that says, look, let's start with honesty, that we'll have a deal that if you're not following it, you'll tell me. As Barry has indicated and various people have said, it's choice. There are choices here. But do we need to reconfigure the contours of that relationship between the practitioner and the patient?
There was a preliminary discussion and there was some disagreement about this, so I'm going to enter the world of fantasy now, and my fantasy, bear with me, there's going to be trouble. Okay, this is the world of big data, and it's the world of mobile phones and iPads and telecommunications, and I can't help thinking that if we know that people are not doing as they're told for all of the complex human decision-making reasons, then I would suggest if we can find some way of capturing what people are doing, and obviously we'll continue to measure things like hospital admissions and how many IV antibiotics and what the FEV1 is, and that'll continue to be part of your national database, that data registry. But if we can also have everybody in the CF community tapping a few buttons on their phone every day about, you know what, I didn't do physio today. You know what, I didn't take my antibiotic. I didn't do this, or I did do that. I ran 3 kilometers. And if somehow we can get somebody really clever at the other end to look back at hundreds of people, say, well, the ones that did this, this, and this, and had this particular profile did well, and the ones that didn't did badly, then I guess that's observing what actually happens rather than kind of hoping for the best. So that's my fantasy, some way in which kind of getting all of the data, complex and real, together might help us one day.
Any other thoughts on things like food diaries? Are we foisting the potential for blame on people if they don't meet the clinical demands? Susan, do you have a thought on that?
Yeah, of course. So I think the food diary is particularly relevant for parents because if I leave my 17-year-old to fill it out, there's probably some RCH dietitians here. They will see that he writes sandwich, dinner for dinner, or something like that. And that's pretty unhelpful. So it ends up falling back to us. And I think... So to be frank, what came up in our earlier discussion was the fact that I had been speaking with some other moms about these CF food diaries and their struggle with them, and basically it came out that of all the people in the group, about 95% said they didn't tell the truth on them. And so when I said, when we talked about why they didn't tell the truth on them, it wasn't because they're people who lie or like to lie or they weren't trying to deceive their dietitians. They just struggled with the sense of being a bad parent and feeling judged, even though, of course, the dietitians were lovely, and that was that was the last thing they were going to do. But that was there's a lot of mums, even without CF, struggle with guilt. So mothers with CF in their lives probably struggle even more. And so it was an acknowledgement, I think, that this is an internal battle that they face, that if my child is thin, that's my fault, right, as a mother, maybe. And maybe that's what I worry about. And so I think that, and so what made me go to thinking, because then I go to think about the system, inevitably, and I think what a shame for the dietitians, because they're spending a heck of a lot of time working out data that's not true, and suggesting things that aren't actually that relevant. I'm sorry. Sorry, friends. I told you we had some things to talk about.
I don't work with food diaries.
That's right. But so then we need to say, well, isn't it better to have the conversation and put it out in the open that we're not telling the truth, and so that we're not all deceiving ourselves, so that we then say, well, okay, what do we need? I mean, it was particularly the moms whose kids were on the on the bottom end of the scale for weight, and then I'm thinking, well, maybe the people who are up in the 80th to 90th percentile my kids would love us, don't need to do the food diary, say, and that could be an incentive actually to get people up on the scale. If you get up to 80th percentile, you don't have to do the food diary. Anyway, and maybe we take a little bit of our eye off of those people and thinking about it in terms of limited resources and say, what, in my view, because I'm really, really big on having people's voice in this, is that we then get the people to come in and talk with us in a really honest, no fingers pointing, nothing leaves the room sort of discussion about what would work for those of you who are in the bottom 10 to 20% to change this, for you not to feel bad. It's not about you feeling bad. It's about saying, in reality, what's your life like? And if giving you another thing of sustagen isn't going to do it, then what is? And you come up with some ideas, and you come up with some things. They may not be what we want, what we as dietitians think is best practice, but then let's find a compromise, because actually it seems to me that health is pretty messy, and it's about combining, real normal life and all its messiness with all sorts of good things that we should be doing, and trying to find a sort of a middle ground.
I think that you always have to look why you use that dietary method, because when you use it to look at the fat absorption, it may be useful, but to evaluate your dietary intake, it can also be with dietary history. So in adulthood, I do not use this kind of methods, but I know that my colleague in Children's Hospital use it. And when patients come to our adult center, they always be very happy that they do not fill in that
Fictional food,
that you say anymore. So, but sometimes you have to use it.
Barry and then John.
But John, you
Oh, no,
go.
John.
I think we spent a lot of time talking about adherence, and to bring it back to cost, Claire showed us some data that for every FEV1 percentage point that there's a reduction in the cost, and that's really just considering traditional therapies, and adherence is the key to that. And we've started by using the ethical framework of shared decision making, which we acknowledge perhaps we're not super good at but could be better, but I think that only takes us so far, and that part of our failings, I don't think it's just RCH Melbourne, but I think lots of places and these big clinics that are coming, is the ability to motivate people, and that's a different discussion. It's and whether we need to have additional resource or divert resource, but being able to find out for the individuals how they're motivated to do their cares is something we need to be better at.
Barry.
I think just going back to what Susan was saying there, in some respects it's the conflict between best practice, which is what you can write in a book, and no practice, which is what you can do when you walk out of the clinic, and how we find a middle ground. And I was saying, for us, what we found very helpful really is the recent Alexandria Quittner paper in CHEST, which basically highlights, across the board, independent of whether it's a nebulizer, an inhaler, a tablet, that a surrogate for adherence, being medical possession ratios, is at about 50%, and that's in 3,500 patients from a registry, and so for me now in the clinic, it's affording me a way in where I can say to somebody, well, if you are doing this stuff all the time, you're an outlier. You're not real, because the single largest study on this, by at least times 5, is showing that in reality most people hit things 50% of the time, and where I'm actually in real terms trying to push people to is if they can get close to 80%, because there's some other studies that would suggest that an 80% adherence really gives you a good outcome with a lot of these therapies. The challenge, of course, is the model of how you do that. Some people will say that if you say to somebody, if you can do it 80% of the time, they'll walk out and say, well, that's really 60. Whilst if you say 100, they'll walk out and say that's 80. But I actually think that paper is really honest and useful, because I think it allows us disarm what is a conflict now, and just say, well, look, this is the data. I mean, admittedly, it's from the United States, so it has to be extrapolated to an Australian or an Irish population. but it's there, and it's basically saying what you as a mother, know, and what patients know when they come into us, which is, they don't always do things, and that's just a reality, and it allows us to maybe engage in it in a less confrontational way.
Right. Now, this is a Q&A session, so I'm about to ask David another question, but I would ask people that do have questions to feel brave. This is an opportunity to ask experts things that might be of great concern to you, so please take the opportunity. But to step one step back, David, to a much more general ethical consideration, as new treatments and new drugs are available and the engagement of the CF community in the development of drugs, should we be looking at a sort of ethical component to that relationship?
Jeepers, that's a loaded question in front of a cystic fibrosis audience. Look, I mean, part of the ethical concerns voiced around the development of ivacaftor in the United States was that there was considerable government money put in, that the Cystic Fibrosis Association was very much involved in the development of the drug that then was going to be used for patients with cystic fibrosis. And then the price at which it was sold in the United States was extremely high. I think $300,000 US per patient per year, and presumably going to be used indefinitely. And an article was written by an ethicist in the New England Journal of Medicine, suggesting that perhaps the pharmaceutical company might be more altruistic about it. And I think that brings up the question of what pharmaceutical companies are in the game for. Are they in there to make the health of patients better, or are they in there to reward their shareholders and keep their jobs? And that's something that comes up in medicine all the time. It comes up in the world of vaccines, which I'm more involved with. But do we expect drug companies and vaccine companies to be altruistic? Or do we expect them to make as much money as they can out of governments? And I think that's quite an important ethical question, and I can guess, you can probably guess from the way I'm phrasing it, the way I feel about it.
Indeed. Now, I'm really going to put it out there for questions. Are there any questions from the audience? If you'd like a microphone, we can provide that. If you have a booming voice, good on you. Any questions?
John,
Mike, I've got one to throw back at David, because I know the answer. The companies are there to make the most money for the shareholders, and perhaps that's what they're going to do. So I had to throw back an ethical question to you, because that you hinted at before, we clinicians have to wear a responsible hat, and you deal with antibiotic stewardship all the time, being careful how you use antibiotics, being careful about multi-resistant drugs. You may not choose, you ought to choose the best antibiotic for this patient who's yours, but you ought to think about all the other patients. And so now, we've always done that a bit with drugs, but as an individual clinician, my job is to advocate for the health of my patient, but I'm also a citizen, and I have to keep an eye on the broader budget, or maybe I don't. How do I do that, David?
In 25 words or less.
Yeah. I mean, I guess what I would say about antibiotic stewardship, if that's what the question is specifically.
It was that antibiotic stewardship's an example that I think we manage easily because it's not costly. But now we're talking specifically about a very expensive medication that I may want my patient to be on, but I'm worried that it's very expensive. And how should I be concerned about the broader hospital, state or federal budget?
So are you saying that we do or don't have responsibility about the overall budget? I can remember listening to an interview in the United Kingdom, and a GP was being interviewed about the use of drugs for asthma. And he said, well, there's one possibility is to use Intal And so disodium chromoglycate, oh yeah, you all know that, but not necessarily all the audience use the same trade names. So disodium chromoglycate or beclomethasone. Okay, should I use one or the other? And he said they are pretty well equivalent. And the commentator said to him, the interviewer, the ABC interviewer or the BBC interviewer said, what's the comparison in cost? And he said, I haven't got the foggiest idea, and I'm ashamed to admit that I haven't got the foggiest idea. And this was the National Health Service, so he didn't care. Well, he should care. That's what the interviewer was saying, and I think we should all care about costs. And so we have some fiscal responsibility to be reasonable. We have to think about all patients, not just our own patients. So we advocate for our own patients shamelessly, and we should. I quite agree that we should. I expect the respiratory... I'm chair of the drug committee in my hospital. I expect the respiratory physicians to come to me and say, I want to use such and such, palivizumab, to prevent RSV infection. And I say, I absolutely respect that. The answer's no. and we have this discussion, and I say the reason the answer's no is because there are so many patients in this hospital that would then get palivizumab that the benefit of what we're getting for it is not sufficient to justify the cost. It'll cost us millions of dollars a year, and we can't afford that. And so I sort of expect some fiscal responsibility, but I also expect people to advocate for their patients.
So, David, if I take away from that the ethical approach is that we have a system whereby someone unrelated to the patient at PBAC or somewhere else, hospital advisory group, makes the decision based on their health economics or whatever factors they use. And the individual who's clinician involved with the individual patient advocates hard at that level, and there's a separation of two. But is that how you see it?
That's exactly how I see it. The problem comes when there's not a clear separation. When the companies try to involve physicians and get them being members of boards and what have you, and then advising the government about who should be getting a drug or not. I'm not specifically talking about respiratory physicians here, but I might be. And this happens again and again. So, for example, at the PBAC, they discovered that all the boards that were advising the PBAC on who should be on rare drugs were manned by people who had conflicts of interest, and mostly undeclared conflicts of interest. So they'd had lots to do with the pharmaceutical companies, but they were also advising about whether the patients should receive the drugs made by the same pharmaceutical companies.
Thank you. Sian, I'd like to come back to you. And first of all, I'd be very interested to hear your response to the discussion of ethics. As a patient, as a person who has gone through the therapeutic responses, is it significant to you? Is that ethical dimension of the discussion something that you think about?
Does the cost to the government for medication, is that something I think about? Not really, no.
Which I think is completely fair enough, personally.
Yeah.
In fact, I'm not really, I haven't been aware of it.
Right. Susan?
Yeah, I was sort of to and froing about jumping in. I think actually that John, for instance, that you should have an absolute consciousness of it as an individual human being in our society with a societal responsibility. Do I want you as my clinician weighing up all the pros and cons and having to think about that? No. No, I don't. I don't think you should. And I don't think that that's the right place. And should I think I should, as an individual human being, as part of this democracy and with sort of responsibility, I should be thinking about it. Should I, as a CF parent, be thinking about it in that same way? No, I don't think so. I just think that that's a very big burden to put on someone as an individual, for Sean or myself, but even for John. I think John is first and foremost, when he's sitting, if he was my son's physician, he should be thinking about their health and their well-being. And to ask him to measure up all of society in that instance, I think is unfair and is not his first primary do no harm and do good to this person. I think that's mixing his responsibilities.
Thank you, Susan. There's a question here, sir. Could I ask you to stand up just so your voice projects more? In fact, if there's a microphone coming, thank you.
I guess what I've heard a lot of what you're all responding to around the cost and things. I guess maybe the session should be called the real benefits of the cost of cystic fibrosis, because ultimately what the summary of what many of you have talked about is we know there's probabilistic benefits of certain treatments. Some of us have thought about some of the costs of those. It's very difficult with an individual. We draw on big studies if we have them, or we have a bunch of small studies inadequately representing the individual in front of us to determine the benefit of this action. It's only probability anyway. There's all these other comorbidities and covariates that are involved in that. I guess if we thought about an individual where we had perfect information about their DNA through to their phenotype, their response to previous activities, and we could project a benefit for this person from some investment in their health, then we would be able to talk more about whether the cost is worth it. But we often don't have an adequate measure of the benefit for anybody of taking a certain action. And it's confounded by will they take that action with compliance, etc. So I guess for the panel, what I'm interested more in is where are we weighing up benefits against those costs, so that it may be difficult for a physician to say this is a good investment for this person. If you're faced with somebody, for example, is not very good with compliance, we probably think we're wasting money. And then we talked about you talked about whether you then have to build common goals and work towards those. But I guess what I'd like to hear more about is how we're measuring the benefits relative to those costs.
Thank you. Would anyone, Barry, would you like to have first crack at that, or Pradeep?
Well, I mean, I think that's an excellent question, but I think that's going to take a long time to truly answer. The nature of drug approval and drug studies is that the vast majority of them are very short term, and that's necessary. But the downside to that is that we really don't fully understand what the long-term consequences of these very costly therapies are, and we don't know them in particular. We don't know them in patients, for example, who have not yet developed chronic infection, because those people have not been studied in the initial trial. So I think that to me, that I would answer that in that I fully understand the societal issues. I agree very strongly that our job is to advocate and realize that somebody has to make a decision, and sometimes the answer is going to be no. But I think that if we give this time, we'll know a lot more. And these costs, which are astronomical, aren't necessarily permanent. And if we can get through this period, hopefully, learn more about what the long-term benefits are, the costs should come down if the natural history of this disease is like others, and we'll know how to answer your question. So it's really not an answer, but I think we just need a lot of time to figure that out.
Anybody else?
I do think, though, one of the key things around these expensive therapies are we need to know more about them, and so I do think it's critical that when you put patients on these therapies, that you put some form of monitoring in, that they're also buying into, that it will inform potentially, how over time their disease may change, and whilst that's an imposition on an individual because they may have to come back to a clinic every 3 months or whatever, I think it is a responsible thing to do as a physician, because you're saying, look, this is expensive, and I want to be able to turn around to government and to society and to say, look, we've done this, and this is what we've been able to show in our particular cohort of patients, and so we have some data back. I think accepting the trial data as enough that you can just go out and use it is not enough, actually. I think if they're expensive. I also think that we often forget some of the savings, and we were discussing this earlier as well, particularly around adult care. Oh, well, actually, it's identical really in pediatric care when I think about it, but when we talk about mothers being unable to work, equally, you know, adult CF patients, when they get sick, they can't work and their partner can't work. And that's a huge imposition on a fiscal level and also just at a societal level, to have two members of society who want to contribute not being able to contribute. And so those costs need to be factored. But I think there's an inherent responsibility on clinicians to put in place mechanisms to follow carefully people on these drugs. And I think the patients have to buy into that. And also even the people who can prescribe it, whilst it might offend some, there should be designated prescribers in some of these, so that at least then it doesn't run away with itself.
Thank you. Eleanor, did you want to say something?
I just wanted to reflect a little bit on the complexity of this, that cystic fibrosis is a lifelong conversation between medical practitioners and patients. And we've heard today from Sian that, you know, in her lifetime, she was non-adherent for quite a long time and then became adherent for different reasons. And
Not non-adherent,
Okay.
just unhappy.
Unhappy. Okay, so I apologise. I'll bring. There's also this idea of a knee-jerk. Well, if people are not going to adhere to a treatment, then maybe we shouldn't give them access, especially if it's expensive or whatever. And I think it's a tiny story, but we've asked a lot of children to do a weekly supervised exercise program, and some of those children have been really annoying, and they've made up reasons to not be available for the exercise week on week on week. And it's normally adolescent females. And I think the knee-jerk for us was to say, well, perhaps, you know, if you haven't been adherent for 3 months, then maybe we should withdraw the offer of this intervention. And I have to say, a couple of times after this 3-month period, you know, a couple of these girls have turned around, have got on board. They're in a different place in their lives. And it's suddenly revolutionized what they've been able to do and what they've been willing to do in a really positive way. And so it strikes me that we shouldn't give up in non-adherence. And it's a long journey. We need to keep trying.
Thank you. And Barry, just to pick up a comment you made earlier, where you said that we have to rethink the whole notion of terrible teens to upstanding adults, that the way in which we understand sort of shift in compliance as a person ages is significant. Could you just elaborate on that?
So again, and my paediatric colleagues I think will concur with this, if the truth be known, adult providers love getting patients from pediatric clinics because we think we're going to fix them, and you know, at last you're coming over now and you're I'm trying to remember that, you know, you're an adult now, so suddenly we're going to take over and make things better. Equally, pediatricians don't like handing over patients, the studies have shown, because they're worried that we won't fix them, we'll make them worse. But the actual interesting thing about the Quittner paper was that the adherence to therapies was best as a child, was not as good as a teenager, and surprise, surprise for me when I saw the data, was worse as a young adult and was worse again as an older adult, and came right when you're in your mid-30s and you're looking at transplantation. I mean, and so in reality, this idea that the teenager is terrible, actually it's not. The teenager is pretty good, actually. It's the adult in the clinic that's telling you about their job and how perfect everything is that are probably less adherent, if we believe the studies. And so I just think it's an interesting, for me, that graph in that chest paper, it was very informative, because I personally believed, and it goes back to what Claire was talking about earlier, about those years where you see the curve change in lung function. Whilst the lung function is better now than it was 30 years ago, the dip is still between 14 and 18 or 19, and a lot of people would say that was as a consequence of being a terrible teen. but I don't think it is. I think it might be, maybe it's in females, it might be estrogen linked or whatever, but the point being, you're actually less adherent the older you get until you get very sick.
Thank you, Barry. David?
And one of the things you said before, Barry, which I thought was fascinating, was that it didn't matter how good the treatment was, how effective it was, or how expensive it was, adherence, people were still non-adherent at the 50% rate on average, even if it was incredibly expensive. And the PBAC did sort of toy with the idea. Don't get me wrong about ivacaftor. I think it is an enormous advance. I think it's a wonderful drug, and I think it's a brilliant piece of engineering. I just think the price is too high, and I'd love it to be more of a partnership, if you see what I mean. But the PBAC toyed with the idea of saying, if people weren't compliant with ivacaftor, we would stop paying for it. And I'm glad to say they didn't go with that, because how do you measure compliance? And, there's reality to life and so on. So it was decided that it was cost effective, even at a very high price, and that the government would pay for it.
Just to say, I may have said that incorrectly. I didn't say that it was based on price. It was more based on time. So you're as unlikely to take a tablet as you are to take a 20-minute nebulizer. Ironically, in that study, I don't know whether patients, and it would be an interesting thing for someone to explore, is the relationship that a patient sees around the cost of something and the adherence or not. Does that point? But literally in the study, and it was a pre-ivacaftor population, it's, there is, people would say, oh, it's a tablet, you'll definitely take it. Well, people took Zithromax as much as they took nebulized tobramycin.
Actually, there's a really interesting study that was done in the United States which looked at placebo, and they had placebo that cost 10 cents or placebo that cost $1, and the placebo that cost $1 worked better than the placebo that cost 10 cents.
Never mind the quality, fill the width. Look, that brings us to the end of this session. I'm aware that, subject as broad and potentially complex of this, we've barely scratched the surface, but we've had excellent scratches on our side. I'll ask you to hold your applause till the very end, but I would like you to thank Barry Plant, Pradeep Singh, Sian Ellett, Susan Bigger, Francis Hollander, Eleanor Main, John Massey and David Isaacs.